Dear colleagues, before starting my presentation, I would like to say that we all missed my dear friend Roman Piotrowski. Rest in peace, Roman. I am so sad about that. Today, I will try to briefly discuss GP mapping methods and GP ablation methods. As you know that we can divide autonomic nerve system, cardiac autonomic nerve system as extrinsic and intrinsic part. And in intrinsic part, we know that there are some autonomic ganglia in epicardial area which contains neural body of parasympathetic and even sympathetic system. But there are also some postganglionated neuronal fibers from this autonomic ganglia to synatrial node and AV conduction system, but these postganglionated neuronal fibers usually travel in myocardial and even endocardial level. So during endocardial cardioneuroablation procedure, we can ablate first this postganglionated neuronal fibers, but our lesion will this area will be transient due to axonal regeneration process. So we should target real autonomic ganglia for permanent damage. According to anatomical specimen, there are at least 1,500 autonomic ganglia around left and right atrium, but in 3 epicardial fat bed site, we see clustering of this autonomic ganglia. The first one is aorta superior vena cava GP. The other one is right pulmonary vein and right atrial fat pad. This area is very close to localization of sinus node. So the usually autonomic ganglia provide vagal innervation to synatrial node located in here. And the last one is inferior vena cava left atrial fat pad. You are seeing the location of this epicardial fat pad around coronary sinus ostium in lower posterior wall of left atrium and usually provides vagal innervation to AV node area. According to physiological experiment, let's look at the right atrial and right ventricular electrogram during baseline, during vagal stimulation, and during vagal stimulation plus atrial pacing. As you know that vagal stimulation should cause negative tonotropic and chronotropic effect. As you see in here, during vagal stimulation, we are seeing a serious right atrial bradycardia. During atrial pacing, there is still right ventricular bradycardia due to AV block. But if you surgically remove inferior vena cava left atrial fat pad area during vagal stimulation, although there is still seen right atrial bradycardia, during right atrial pacing, we don't see right ventricular bradycardia, so we eliminated vagal innervation of AV node. Then if you surgically remove right atrial and right pulmonary vein fat pad area, close to synatrial node, and during vagal stimulation, you don't see right atrial bradycardia. This area is important for vagal innervation of synatrial node. But if we are talking about a human, this actually distribution seems a little bit more complicated, but I tried to combine a real anatomical schematization of armor and our 3D mapping data with Professor Danius Pausa. And as you see in here, right superior GP located in anterior wall of right superior pulmonary vein and posterior septal wall of superior vena cava, and usually provides vagal innervation to synatrial node with right inferior GP. You are seeing the location of this GP. The great majority of autonomic ganglia for synatrial node located in both GP area. The other GPs like superior left lateral GP, posterior lateral left atrial or left inferior GP, usually located tiniest GP site and rarely provides vagal innervation to synatrial node and AV conduction system. But posterior medial left GP located in inferior vena cava left atrial fat pad area, you are seeing the location of this GP with different view from left atrium and right atrium, and usually provides vagal innervation to AV node area. But please remember that, as I mentioned in my first anatomical slide, this autonomic ganglia provides postganglionated neuronal fibers to synatrial node or AV conduction system. So during ablation around synatrial node or AV node area, you can firstly eliminate this postganglionated neuronal fibers from autonomic ganglia to target organ, but although you see a similar acute success like increase on sinus rate or resolution of AV block at the beginning of the ablation, for permanent damage, we should target real autonomic ganglia site. Different groups use different techniques. Professor Pachon created the CNA and used spectral or fast Fourier transform analysis. I will not explain the details, but maybe we can briefly talk about high frequency stimulation. Basically, if you perform high amplitude and high frequency stimulation in autonomic GP area, you should cause a vagal discharge. So you should see a RR prolongation or PR prolongation due to vagal effect. But different groups use very similar technique. But if you look at here, Kim et al. Tried to define the distribution of GP based on HFS response, but they found very irrelevant area showing positive vagal response. The reason I think that we are using very large tip ablation catheter, so we can do non-specific vagal discharge due to very high amplitude and high frequency stimulation like PFA application. It's very time consuming. There is no consensus for prepared protocol, any RR prolongation, or should we see more than 3-second asystole to say positive vagal response? But I think that the most important limitation is AFib induction. I would like to mention just 2 examples about the HFS response. For example, according to our experience, we are seeing fragmented electrogram and we are on right superior GP area. And during HFS application, we couldn't induce vagal response. Actually, we induced atrial fibrillation. But we are in left inferior GP area. Again, you are seeing very fragmented electrogram, very compatible with the left inferior GP. During high frequency stimulation, we are seeing a clear vagal response. I think that if you want to use high frequency stimulation and if you induce atrial fibrillation, you should accept as another autonomic response. And you should say this is another vagal response. In other ways, you can miss the great majority of GP by using high frequency stimulation. This is the approach of Dan Wichterle, my dear friend. They just perform pure anatomic ablation via left and right atrium. It's very reasonable technique because if you remember my anatomical schematization, great majority of GP is already located in midline area between left and right atrium. So without using anything and performing ablation in that area, you can eliminate the great majority of autonomic ganglia. De Bruyne use pure anatomic, very limited right atrium only approach and see very similar acute success rate. But as I mentioned before, this effect can be related to axonal degeneration in post-ganglionated neuronal fiber sites. So you can eliminate extravagal stimulation response as well. But for longer term success, we need real autonomic ganglia effect. According to this basic study, Laluce performed divided electrogram characteristic based on vagal response during RF application, and they found that if you see more than 3 or 4 deflection on electrogram, you will see more vagal response like high frequency stimulation. And then Professor Pachon compared different bandpass filter setting to calculate the real number of fragmentation on electrogram. Look at that. If you use classical electrophysiological parameters, you can miss such a fragmentation on electrogram. But if you increase your high pass filter to 200 or 300 Hz, it will be easier to find such a fragmentation on electrogram. So different groups used combination of electrogram analysis and anatomical landmarks. And as you see in here, by changing the bandpass filter to 200 and 500 Hz as suggested by Pachon, we are trying to find such a fragmented electrogram in possible GP area. And we compared this technique with combination of high frequency stimulation plus spectral analysis, and we found shorter procedure and scopy time with a similar effect on heart rate variability and syncope burden. Recently, Timothy Markman from USA checked the epicardial fat pad thickness on CT and try to define whether there is any correlation between epicardial fat pad and fragmented electrograms, and they found a very good correlation between thicker epicardial fat pad area and fragmentation on electrogram. I would like to briefly explain two software. The first one is fractionation mapping software. Try to calculate the number of deflection. For example, if you select two as a fractionation score, the area more than 2 deflection will be colored with white, like in here. In purple area shows classical electrogram without deflection. And as you see in here, we can detect the localization of GP by using this software. And recently we tried the combination of fractionation software and peak frequency software. And actually in peak frequency software, the system tried to show us maybe more than 300 hertz electrogram area, and combination of fractionation software and peak frequency software with different hertz selection, you are seeing the localization of GP very, very clearly. And look at that. For example, in this example, this area shows both fractionation score more than 2 deflections and peak frequency level higher than 500 hertz. And this is the target area. And during RF application, you are seeing very clear Wagar response. This is another example. Again, white area is our target site. We are very close and you are seeing the Wagar response. This is another example. We are in the posterior medial left GP area. Again, during RF application, we are seeing very clear Wagar response during RF application and a little bit PR prolongation. So now I would like to say the new era in GP mapping, a combination of 3D CT and 3D map. Look at that. In this 3D CT image, this area shows epicardial fat pad, and we also see the location of esophagus, phrenic nerve, or other sinoatrial node artery, other important area during RF application. Look at the location of right superior GP, left superior GP, right inferior GP, and posterior medial left GP, very close to esophagus. And then we can combine 3D CT, epicardial fat pad, and 3D map, fractionation score, and peak frequency map. And then we can easily ablate this area. Thanks for your attention.